colleagues. I'm Alexandru Mischie. I'm an interventional cardiologist at Centre Hospitalier de Montluçon in France. I'm so happy to see you again after this vacation. We have a very exceptional webinar today with exceptional panelists and speakers. Just a small word about our society. The International Society for Telemedicine and E-Health has around 40,000 members worldwide, and our working group has around 3,000 members, cardiologists and paramedics. I would like to thank to all of the speakers and the panelists for joining us. I know their time is very valuable, and without further delay, I would like to give the word to Dr. Biljana Parapid from Serbia, which in fact organized this webinar and launched all the invites. So thank you so much, Biljana, for your time. And please, you have the word.
Thank you so much, Alex. Dr. Mischie is a very faithful ally for years now, and we've been pitching this one to the other, who's going to organize each of these things. And this time it was my turn. I'm extremely happy, and I'm extremely honored that Professor Luscher, Professor Mehran, and Professor Stojšić-Milosavljević will be joining us as panelists. Professor Luscher is already here. Thank you, Professor. We know that it's a Friday evening in Zurich, but we appreciate it. We will try to keep on schedule in 60 minutes. Professor Mehran is on her way after landing on the West Coast, so she will join us towards the end. And Professor Stojšić-Milosavljević is the Madam President of the Serbian Society of Cardiology, got an unexpected government visit in her hospital center. So she will be joining us on audio for the discussion, because those were some surprise events from this late afternoon. As you probably do not know, Serbia is getting a government in the next week, and of course we're a government-owned system, so when government pays you a visit, you have to be there. I would also like to thank our usual suspects for all our webinars in the past years that always have time for us. And I will start with the screen with Dr. Alessia Gimmelli from Pisa, Dr. Dominik Linz from technical line, Dr. Mirvat Alasnag from Jeddah, Saudi Arabia, Dr. Christina Chrysohoou from Athens, Greece, and Dr. Aaysha Cader from Bangladesh. Without further ado, I will go immediately to I promised we will not talk more than 5 to 7 minutes, because by now everyone has pretty much seen both the guidelines and the highlights and what was presented. So I focused more on the comments of what we have seen. So the things that I will show you now is something I was tasked to do. Our amazing Aaysha Cader was distributing these things in just a second.
Thank you. So Biljana, you will present the prevention part of the Congress, this very beautiful Congress, the ESC Congress, which took part in Barcelona. Sometimes we're having trouble hearing you.
I don't know how to make it better, to be honest. I only search for a mic, but I think
now it's okay. Or maybe
okay, I won't move.
I
won't move. I won't move. Let me just see why my screen is not showing what I wanted to show. And normally I don't have problems with this.
Now everything is okay. We can hear you okay.
I'm sorry. Just a second. It's not at all showing me the presentation that I have opened. So let me try like this and see what happens now. Here, finally. Okay. So thanks everyone for joining us. So I will start with something that does belong in the prevention, and that was the Marfan syndrome trial that was actually a meta-analysis, but not a simple meta-analysis. It was a meta-analysis that included original data from patients from 7 registries or trials that have been already published by a group of people who've been working on this for decades. My own conflict of interest pertaining to this was I was trained at Mischie, also with Professor Guillaume Jandot, who's one of the co-authors on this paper. This initiative is majority people Aaysha actually is the National Center for the National Referral Center for Orphan and Genetic Rare Diseases. So actually in that section that Aaysha gets also the genetic analysis.
Sorry,
So,
Biljana, the sound is
it not, do you want me, is this better now?
yeah.
Okay, I will speak louder, sorry. So simultaneously, it was published in The Lancet on August 29th. We didn't see this data presented during the ESC, but they had a very nice gender balanced sample. And what we have shown is that although the guidelines are currently recommending use of beta blockers, ARBs have been demonstrated to show beneficial effect in terms of control of the enlargement, both of the Z-score at the aortic root and of the rate of increase of the aortic root, which we all know is a hallmark for timely surgical management, because sudden cardiac death in patients who are unaware, who are not all typical Marfan syndrome patient, we all know what a Marfan syndrome patient looks like. But what is also more important is that actually the ARB effects were particularly large in patients who were carriers of the fibrillin 1 mutation, which implies the interaction of the RAS system, the TGF-beta pathway, which actually opens the door for timely and more detailed preventative screening of populations. We here, sorry. So I'm moving to the two trials that we're discussing, both primary and secondary prevention. The first one was the DanCanvas trial, which was conducted in Denmark. And it was actually, they started recruiting some 10 years ago, and they published simultaneously in the European Heart Journal just some weeks ago, showing actually the timely screening of men over 65 does also not only improve outcomes, but they linked it also in their publication to cost. And we can see here that the average cost of healthcare in Denmark didn't increase it, actually didn't increase the cost more than 207 euros per patient. Sadly, as Dr. Harriet Van Spal from Canada, who was the commentator for this trial, noted, this was a trial that was government sponsored, but enrolled only men. We very well know that Denmark is not inhabited only by men. At least they have also a queen, and she inherited that from her mother. So they know women exist. So we're a bit appalled that not only they were screening just men, but they're currently doing something like a phase 2 that was also budgeted by the government, but it also doesn't include women. I don't know why my slides are not wishing. So yes, finally, no women included at all, no info on racial profile in the publication either, although we potentially assume they're all Caucasian. The second trial that was dedicated more to secondary prevention was actually the first randomized clinical trial testing the efficacy of a fixed combination polypill. And as we all know, Professor Fuster's polypill that was designed some almost 20 years ago, we have been all prescribing around the world. This trial is dedicated to speedy prevention in elderly over 65. It was conducted in Spain, Italy, Germany, France, Poland, Hungary, and Czech Republic. So we can say that they were also mainly most likely Caucasian. They showed that the fewer recurrent cardiovascular events following MI was presumably due to improved adherence. To remind all who don't remember it, the polypill contains actually a fixed combination of 100 milligram aspirin. We can debate now whether 175 would be enough, but not for secondary prevention if we're using it for primary. Ramipril of 2.55 or 10 milligram, and atorvastatin of 20 to 40 milligrams. Now, it also depends on the portion of the world we're focusing. Not all these versions exist. For instance, in Serbia, we have the version with only 20 milligram of atorva, but not the 40. Was it needed? Yes, I'm sure their website is currently, I checked it yesterday, they still don't have some more info.
Biljana, I'm sorry to cut you. So the sound is still an issue. Just I don't know if you can.
I don't know how to improve my sound. That's my other
put yourself
problem.
a bit closer to the computer, or.
Yes, I can do it like this. The only trial that we have seen that actually extended and is something that is a very good take-home message is the Fourier-Olé, which showed their primary results. And we have seen that the almost 4,000 people who were randomized to evalucumab and 3,300 to placebo from Fourier continued their follow-up. Actually, they accepted to self-inject 140 milligram every 2 weeks or 420 milligrams monthly. The median follow-up in the extension study came to 5 years. The maximum exposure was extended in both trials to 8.4 years, and we can see the decreases that we have seen, which have been demonstrated both in Fourier and Fourier-Olé, should encourage us in function of changing practices in our own respective corners of the world, of course, in function of whether it's also feasible from the financial point of view. Finally, the time trial. I think there is no person who has debated whether their patient should be taking their hypertension meds in the morning, midday, or evening. I think that one of the things that have been, in this particular case, they have shown it doesn't matter. Okay, that's a good news. It's especially a good news for people who are working night shifts, especially good for people. We have seen now people from different corners of the world working in different time zones. We know that changes in circadian rhythm also increase our susceptibility to different kinds of diseases. So this is a good news for everyone. Sadly, no info also on percentage of women included or racial profile. I think that there is not a soul in the world who wasn't touched by Her Majesty's demise yesterday. When I posted this yesterday, I wasn't thinking about this talk right now, but actually as I was wrapping up my slides this afternoon, it occurred to me as I was searching for a punchline, so to speak, joke, and this is not a joke, this is a sorry truth, that sadly, if we keep up with this rate of excluding women in trials, I think none of us who lived to see Her Majesty live 90-something will attain 70-something. So thank you all for your time. I think I didn't push it beyond 7 minutes. If I did, okay, I'm gonna get a slap on the wrist in the end. Thank you.
Thank you so much, Biljana. There was some minor sound issues, but thank you so much for this excellent presentation. Without further delaying the webinar, I would like to present Dr. Alasnag from Saudi Arabia. Hello, Mirvat. Thank you so much for joining us. You have the word on interventional cardiology trials.
Well, thank you, Alex, for having me, and thank you for organizing this again. I'm going to try to stick to my time, and you always have us under this rapid fire to present the trials. So I tried to select the most relevant ones. The first one that created quite a buzz at ESC was the revived BCIS-2 trial. This was a randomized trial that examined both the efficacy and safety of PCI in patients with left ventricular dysfunction, defined as an EF equal or less than 35%, with extensive coronary disease and demonstrable viability in at least 4 segments, and was amenable to PCI. So those that were not amenable to PCI were excluded. And viability, for the most part, was done by CMR, over 70% of those enrolled. Exclusion criteria included MI within 4 weeks, decompensated heart failure, sustained ventricular arrhythmias within 72 hours. About a total of 700 patients were enrolled from 40 centers in the UK. Randomization was 1-to-1 to PCI with optimal medical therapy versus optimal medical therapy alone. And the median age was about 70 years, 88% were men, mean EF was 28%, so these were quite sick patients and quite old. The primary outcome was a composite of all-cause death and hospitalization for heart failure. Secondary outcomes were monitored at 6 and 12 months for quality of life and improvement in LV ejection fraction. The follow-up was about 3.4 years, so for the primary outcome, occurred in 37.2% of the PCI alone arm and PCI plus optimal medical therapy arm, and 38% of the optimal medical therapy alone arm. So really there was no difference and there was no benefit incurred from PCI. There was also no significant difference seen in the major secondary outcomes. Given that only patients with demonstrable viability were enrolled, this challenges the concept of myocardial hibernation, which is actually non-discriminatory in the prior STITCH trial. Quality of life favored PCI in the initial 6 to 12 months, but really was not carried through to 24 months of the trial follow-up. What I take out from this trial is that this is a very high-risk population where 1 out of 3 patients either died or hospitalized for heart failure during the follow-up period, irrespective of the treatment, whether it was PCI with medical therapy or medical therapy alone. The next trial was the FRAME AMI. It was an investigator-initiated open-label trial in 14 sites, 1-to-1 randomization, and it was done in Korea, 1-to-1 randomization where patients with an acute myocardial infarction and multivessel disease underwent successful PCI of the infarct-related artery were assigned to either FFR-guided PCI of the non-infarct-related artery, where a significant FFR was defined as equal to or less than 0.8, or angio-guided PCI of the non-infarct-related artery, where significance was defined as more than 50% stenosis. A bit surprising. Complete revascularization was recommended to be done during the index procedure. If not, they permitted staged, but again, tried to encourage during the same hospitalization. And the primary endpoint was a composite of all-cause death, MI, and repeat revascularization. And it was between 2016 and 2020. 562 patients were enrolled, average age 63, only 16% were women. Non-infarct-related arteries were treated by immediate PCI in approximately 60%, 40% in the same hospitalization. So the follow-up of 3.5 years, the primary endpoint occurred in 18 of the 280 plus patients in the FFR arm and 40 of the 270 plus in the angio alone arm. So death was significantly lower in the FFR group, MI was significantly lower in the FFR group, and the MI was significantly lower in the FFR group compared with the angio group. 10 patients in the FFR group had an unplanned revascularization compared with 16 in the angio group, and of course they persisted through the 4 years of follow-up. What do I take from this? I take it with a pinch of salt. It was done in an exclusive population in Korea. We need to interpret it in the context of the totality of evidence. So we know about the Flower MI that was already published in the New England Journal of Medicine that really showed no difference between the FFR and angio-guided strategies for hard endpoints of death, non-fatal MI, and unplanned hospitalizations or urgent revascularization. Next trial is the ischemia CKD Extend, which was really a pre-specified analysis of the ischemia trial. The primary results of the ischemia CKD trial have been previously reported, and we know that there was no difference in the quality of life or hard endpoints in terms of death or non-fatal MI in patients who have advanced kidney disease and underwent a strategy of invasive plus medical therapy versus medical therapy alone. So in the extended arm, basically this was over 770 patients. eGFR was less than 30. Mean age was 63, 31% were women, and randomly allocated to an initial invasive strategy, which consisted of cardiac cath plus PCI or CABG if suitable, with guideline-directed medical therapy, or an initial conservative strategy of guideline-directed medical therapy with cath or a revascularization of sorts if failed guideline-directed medical therapy. The interim results were published, and there was no reduction in the primary outcome of death or non-fatal MI. It's planned to continue for a total of 9 years. The follow-up now at 5 years has been reported at ESC, and a total of 305 deaths occurred, of whom 158 occurred in the invasive group, 147 in the conservative group. Again, there was no significant difference in death between the two groups. So conceivably, medical therapy works in advanced CKD in patients with chronic coronary syndrome, even in the presence of documented ischemia. Next is the MASTER DAPT trial. This was again a pre-specified analysis of the main MASTER DAPT randomized trial, where the trial actually confirmed that the absence of ischemic reduction and reduction in bleeding with abbreviated DAPT in patients with high bleeding risk. So remember, the MASTER DAPT was looking exclusively at patients with high bleeding risk, and patients with both chronic coronary syndrome and acute coronary syndrome underwent PCI with a very specific stent, a biodegradable polymer. So we need to understand if this applies to other types of stents, because it was exclusively with one type. Patients free from ischemia and bleeding events and who adhere to DAPT regimen were randomized to immediate DAPT discontinuation versus treatment continuation for up to 1 year. 1 month DAPT was non-inferior for the net and major adverse cardiovascular and cerebrovascular events and associated with lower major or clinically relevant non-major bleeding at 11 months. This again was published already in the New England Journal of Medicine. And what was interesting here is that the 15-month follow-up, they managed to follow up patients for about 99% in both abbreviated and standard arms, which is really a humongous achievement for the master DAPT trialists. And when you look at guidelines, recommended that patients not on oral anticoagulation should discontinue DAPT, but more than 15% of those of the non-oral anticoagulant patients were still on DAPT at 15 months, which was approximately 3 times higher than the corresponding figure in the abbreviated arm. So similarly, although guidelines for those recommended to have oral anticoagulation if free from recurrent ischemic events or repeat interventions, they should discontinue single antiplatelet. More than a quarter were still on single antiplatelet in the standard DAPT arm. And so what you do see here is a tendency that the prior allocation to abbreviated treatment was a strong predictor of having continuation of the prior regimen. So this is what we call carryover bias. So in spite of the guidelines, there is a tendency to continue the regimen that was specified during the course of the trial. Next is the radial trialist collaboration. This was the first large individual patient-level data meta-analysis. It was multi-center, and the impact of radial versus femoral artery access for coronary angiography with or without PCI, and they looked at mortality and major bleeding. The meta-analysis included 7 trials. Over 21,000 patients were enrolled, of whom 10,000 were randomized to transradial and another 10,000 randomized to transfemoral. Median age 63, 31% were women, 95% had acute coronary syndrome, and 75% underwent PCI. The major outcome was all-cause mortality at 30 days, and the co-primary outcome was major bleeding at 30 days. All-cause death was lower in the transradial arm compared with the transfemoral arm, and it was statistically significant. Major bleeding was also significantly reduced in the transradial arm compared with the transfemoral arm. Survival benefit was confirmed irrespective of the strategy, whether it was per protocol analysis, whether it was as treated. When they looked at the patients who underwent PCI compared with those who got diagnostic caths only, those with ACS versus CCS, and women, and those with baseline anemia. In other words, transradial was really found to be superior. These are the 7 trials. These are all known trials, the Matrix, Rival, Safari, etc. And they did look at Safari PCI for women as well, and so that's reassuring that we're paying attention. And again, you can see here there was significant reduction in mortality in the radial compared with femoral. And again, whether you look at it in terms of PCI or not, MI or not, intention to treat per protocol, etc., they all favored transradial. And to wrap up, there were 2 important trials, the Pacific Stroke and the Pacific AMI. The Pacific Stroke trial did not reach its primary endpoint in this exploratory analysis where they looked at inhibition factor 11A that was used to reduce ischemic stroke and TIA without increasing bleeding. The Pacific AMI trial assessed the pharmacodynamics and safety of 3 different doses of the same drug compared with placebo in patients who are on dual antiplatelet therapy consisting of aspirin and a P2Y12 inhibitor following an acute myocardial infarction, and over 14 countries. Important to remember that these are phase 2 trials, both of them, with the purpose of investigating the safety and optimal dosing for secondary prevention. You need a phase 3 trial in order to make any concrete conclusions about the hard endpoints and outcomes, which are underway, I believe, for these trials. So that was a very quick wrap up, and I think I did keep it under 5 minutes. So thank you, Alex and everybody.
Thank you so much. You're amazing as always. Without further ado, I'm giving you Dr. Alessia Gimmelli, a cardio nuke guru we all admire. And I'm zipping it. Alessia, it was yours.
You have to activate the sound, Alessia, please. Just activate the sound.
Can you hear me now?
Perfect. Thank you.
Yeah. So thank you very much for this kind invitation. The role of my presentation is to highlight the role of imaging. Imaging is also the topic of the last ESC Congress. So imaging is everywhere. And I would like to put your attention on the guidelines on pulmonary hypertension, because something has changed if we compare to the previous one. And
you accidentally muted yourself.
Yeah,
I think. It's okay. It's okay.
They're not. So
Yeah.
sorry. Yes, and I would like to start with this flow chart, because as you can see here, for the definition of pulmonary hypertension, you need to keep in mind that you need to have the evaluation of the cath lab, and to evaluate the pulmonary congestion, and the gold standard is the cath lab, but echo has a great role in the evaluation of pulmonary hypertension, not only for diagnosis, but also for prognosis in the different clinical classification and in the prevalence of all the pulmonary hypertension disease. And so sorry. Okay, this is the definition according to the hemodynamic characteristics. So pulmonary hypertension and precapillary pulmonary hypertension, isolated post-capillary pulmonary hypertension, and combined and exercise. So you can find everything in the guidelines. We have a few minutes. It's not possible to go in deep, but that's it. And this is the first main topic relative to what is new, and it is recommended to assign an echocardiographic probability of pulmonary hypertension in the first evaluation, in order to stratify not only the risk of the patient, but also the flow chart of the patient in terms of investigation. And as you can see here, you need to evaluate the peak tricuspid regurgitation velocity, and according to the measure that you perform during your echo, you can have a sort of probability of having pulmonary hypertension, and according plus also additional echocardiographic sign, you can go through different kind of flow chart in order to investigate in the best way your patient. So this is completely new, and it emphasizes in some way the role of non-invasive imaging in the evaluation of this very difficult patient. But so echocardiography is recommended in a patient with liver disease or portal hypertension, and all these patients should be submitted as a screening before liver transplantation. So also in this way is completely new. So again, echo is very important for the stratification of this kind of patient. But so this is also completely new. There is stratification at the time of diagnosis, not only for the diagnosis, but also for the follow-up. And again, non-invasive imaging has a great role, as you can see here. You can have a sort of 3-strata model: low risk, intermediate risk, and high risk. And you can have a sort of point flow chart. You need to start from symptoms, and then you can go through the CPET and biohumoral markers. And after that, to echo, and eventually, in case echo is not enough, to CMR. But CMR, of course, is a sort of second choice, and echo represents the first choice for non-invasive evaluation in this kind of patient. You can go in detail in the new guidelines. You can download from the ESCardio website without any problem. So you can have all the evaluation, all the flow chart, and the threshold for your clinical practice. And finally, of course, hemodynamics that represent the gold standard for the diagnosis of your patient. And So this is for the guidelines, but I would like to put to your attention also again on the role of ECO in this incredible trial performed by the Australian colleagues, and they would like to assess the role of ECO for the evaluation of patients with aortic stenosis, and in order to stratify and to use artificial intelligence in order to be of help to clinicians to stratify and to assess the risk of this kind of patient in order to reduce mortality. So as you can see here, the flowchart for the evaluation of aortic stenosis is very difficult, and you need to have lots of threshold and cutoff when you try to evaluate your patient, and sometimes it could be very difficult to define in a very good way your patient, because you need to know the mass, you need to know the pressure, you need to know lots of things. So in this kind of setting, the role of artificial intelligence could be really of help. And here you can have the strategy that they follow, because they were able to enroll lots of patients from all the Australia using the national database of Australia. And so the aim of the study was to create from this database a sort of machine learning approach. And after the training of the systems that they created, they at the end evaluate all the patients in order to create this predictor model. And as you can see here, they performed the investigation in lots of individuals. So the system is very robust at the end. And if you analyze also the follow-up of this patient according to the model, you can see that this model is very useful in the stratifying the patient. So it means that if you can perform ECO and if you can use this system, you can stratify your patient and you can have the best approach in order to be more or less aggressive in terms of treatment to this patient, and to improve the follow-up of the same patient. So at the end, the artificial intelligence can be of help for clinician in order to manage difficult patients. And finally, the last trial, this is another very interesting trial performed by the Danish group. They are related to patients with suspected or known coronary artery disease. In Denmark, they used the CT for as the first choice for the evaluation of this patient. So anatomy first, and then as second choice, they use a functional test for evaluating eventually the presence of stenosis in order to treat in the best way the patient. And they try to use a different approach. So the functional approach was related to rubidium PET or to CMR in order to stratify and to evaluate which is the best test for this kind of patient, because as you know, these two techniques are a little bit different in terms of what they show. And again, if you perform in a very correct way in the best patient, so also different kind of tests at the end, the choice of test is relevant, but not so relevant, because if you compare to invasive FFR or to presence of stenosis, the two tests are quite comparable. So it means that you need to have an anatomy, but you need to have also the functional evaluation in order to be sure that you are able to treat in the best way your patient. So you can discuss a lot about which is the best strategy for the evaluation of functional tests, but at the end, again, the combination between functional and anatomical approach could be probably the best one in order to treat your patient. Thank you very much.
Thank you so much, Alessia. Brilliant presentation. We will pass the word to Dominik Linz from Maastricht, the Netherlands. Thank you so much, Dominik, for joining us. You have the word and the screen. Dominik will present arrhythmia updates.
Yes, thank you very much, particularly also for having me. And I will just go through some of the best presentations and also the highlights, of course, of the ESC focusing on arrhythmias. So one of the highlights was, of course, the VT guideline, which was presented by Katja Sappenfeld and also Jakob Twelft. And I will, of course, not now in detail go through those guidelines, but I will particularly focus on two things which will change what I will do, for example, in the future. And this is first, the recommendations concerning ablation of premature ventricular beats, particularly from the right ventricular outflow tract or also from other locations. And here you can see that for most of those scenarios, ablation has now a class 1 indication, particularly if those premature ventricular contractions are coming from the right ventricular outflow tract. So there's no role actually to starting by antiarrhythmics in all of those cases anymore. We really have now also the option directly to go to ablation. And of course, particularly in those patients where also the left ventricular ejection fraction as part of cardiomyopathy can occur due to particularly monomorphic premature ventricular contractions, where we normally, of course, very often still used antiarrhythmics or beta blockers. Now we can directly go to ablation. And the other highlight, which is also interesting, are some prediction models, particularly for non-ischemic cardiomyopathy, and their genetic testing, including some specific genes, is now also clearly recommended as one of the risk factors in those patients, particularly also in the younger patients. And this is very important because if you here look at those graphs already quite early, genetic testing distinguishes how you can then actually further assess the patient and the risk in your patient, and also to decide whether a patient might or might not need an implantable device. A summary and also really something for your pocket is also provided on the ESC website. And those are first, of course, the pocket guidelines, which we know, but also different guideline apps. And in those apps, also those risk scores are really practically provided, where we can put on in the patient characteristics, but then potentially also the result of this genetic testing and other things to really get very quickly the risk in our patients. Another study which was interesting to me was this study. So that's the eBrave AF trial, which was presented by Axel Bauer. It's now published also in Nature Medicine. And the idea of this trial was actually to identify whether simple apps using PPG are able to first detect atrial fibrillation, but second also whether this might have an impact on some identification of patients with and without atrial fibrillation. And what they did is that they had a completely digital and remote trial. It was sightless, digital and randomized trial without any in-person contact. And they randomized either to digital screening by an PPG app and then confirmation of atrial fibrillation by an ECG loop recorder versus usual care. And what they actually found is that, of course, first, PPG screening identified more atrial fibrillation, but interestingly also more atrial fibrillation, which was then afterwards treated by anticoagulation based on the CHETS-VAS score. And what they actually summarized in their conclusion is, first, that they identified a pathway which is scalable and digital. Second, they said that this should be generalized also for other apps, not just the app which is used in this trial. And then at the end, of course, they also say that this result of the study mainly identified atrial fibrillation requiring anticoagulation, but whether this really also results in better outcomes in the long term, well, this needs to be investigated, of course, in future studies. Then there were a lot of AI trials, for example, also the EchoNet RCT. So this was an artificial intelligence trial randomizing scans of the heart, either to artificial intelligence initial assessment or to sonographers. And this was actually a non-inferiority trial, mainly focusing on the assessment of left ventricular ejection fraction. It was interesting to see that first, this trial actually matched this non-inferiority result, but second, it was even superior. So in comparison to a core lab, really already here, this artificial intelligence algorithm could more accurately assess ejection fraction. But interestingly, they also also tested for the implementation of those results. So they found that cardiologists were less likely to substantially change their final report if they already had before artificial intelligence information available. So they really trust the AI results. And second, a cardiologist who actually has the AI information available needs less time to really write and then finalize the result. It was 54 versus 64 minutes. Then there was another trial which was also interesting. This was a trial using causal artificial intelligence to more or less predict the effect of different interventions and trials. And what is actually causal artificial intelligence? So this actually is a new generation of artificial intelligence algorithms which utilizes causality to go beyond narrow machine learning predictions. So it can really focus on the intervention, which might be interesting to look at. And here you can actually see those graphs. For example, here's the HPS trial focusing on the effect of LDL lowering medication, then the SPRINT trial focusing on lowering of blood pressure on outcomes, and the HOPE-3 trial focusing on LDL and blood pressure reduction. And you can see here up the results concerning prediction of this outcome in this publication by artificial intelligence algorithms which were used until now. You can see that they are actually not the same. It's actually lying in between. But if you look here at this lower graph, you can see that this new generation of AI almost exactly can predict the outcomes in those patients, mainly focusing on the baseline risk and also the intervention, which is then performed in those trials. So this really means that embedding causal effects in this artificial intelligence algorithm can more accurately estimate baseline cardiovascular risk, and might also actually in the future really help first to assess individualized and personalized the risk in our patient, but second, also predict more or less and also help to guide the design of future studies. So my highlights are first, of course, the ESC VT guideline, focus on ablation risk assessment using genetic information, and also the practical apps which are now available on the ESC website. Then eBrave, so mHealth's guided digital AF screening is possible also in a big range and can identify AF patients requiring anticoagulation. EchoNet RCT really means and shows that artificial intelligence can be helpful in assisting EF assessment and is already ready to prime time, and also showed that this can be implemented in what we as cardiologists do. And causal AI, the new generation of AI, which may help to guide individual treatment in the future. Thank you very much.
Luscher probably has a question for all of us right now, because we're also almost nearing 1 hour, like in 17 minutes. Do you want to pitch in with a comment for what we have done so far, or we can proceed with heart failure and the potpourri at the end?
Go on with heart failure. That's fine.
Okay, thank you so much. So without further ado, I give you Dr. Christina Chrysohoou from Athens, Greece, a heart failure expert we all love to hear.
Hello, thank you for the participation. This is a privilege for me. I think it was a very interesting congress for the topic of heart failure, and one of the first studies that I would like to introduce, it was just presented by Dr. Dominik Linz, so I'll just skip it and go to the hotline about SGLT2I inhibitors in the liver study, patients with preserved and mildly reduced ejection fraction. The DELIVER study was a double-blind international trial that included more than 6,000 patients with symptomatic heart failure and ejection fraction above 40%, with other chronic outpatients hospitalized or recently hospitalized, and they were randomized 1-to-1 to receive dapagliflozin 10 milligrams once daily or placebo therapy, in addition to standard of care therapy. The primary endpoint was a composite of cardiovascular death or worsening heart failure event, heart failure hospitalization, or urgent heart failure visits. Over the median, 2.3 years, the occurrence of the primary event was reduced with dapagliflozin about 16% versus placebo, which was 19%. And so we had a hazard ratio, a ratio about 20% that was beneficial for dapagliflozin according to the primary outpoint. Furthermore, total hospitalization, cardiovascular death was also reduced by dapagliflozin, and also there was a reduction, improvement in quality of life as this was assessed with a Kansas City cardiomyopathy questionnaire. So this was a positive study for dapagliflozin in heart failure with preserved ejection fraction.
Sorry, Christina.
Yeah, sorry, your slides are not. It didn't show on the show. Can you just click on the show?
Yes.
So sorry.
On the show.
Full screen.
No. Yeah.
I'll do that again. Maybe. Yes, here.
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 Perfect. Thank you
Can
so
you
much.
see it?
Excellent. Excellent.
Sorry.
No. Sorry.
But another problem is that I cannot. Yes.
The arrows are.
Yes, because I cannot play it in full screen. That's the problem.
You can go in full screen.
Yes.
And the arrows
yes,
are.
I can go there. I can go there. Yes. So there was another pooled analysis that investigated the effects of dapagliflozin across the full spectrum of ejection fraction. And this analysis included more than 11,000 patients in the two trials, the trials of DELIVER and the diagram of DAPA-HF. So the investigators wanted to see if dapagliflozin was effective across the entire left ventricular ejection range, since the April preserved trial previously suggested that the effect of another SGLT2I, dapagliflozin, may be attenuated in patients with higher ejection fraction. So this study showed that there was a reduction with dapagliflozin of the risk of cardiovascular death by 14%. There was also a reduction in all-cause death and total hospitalization admissions for heart failure. So it was again a positive study that showed that dapagliflozin can be effective in the whole spectrum of ejection fraction from reduced to preserved EF. Another study was the meta-analysis of that included DELIVER study and temporal preserved, tried to show that in patients with reduced EF, if those medications can have a class effect and not that beneficial effect can be due to either of each one. This study, with data were pulled from the two big studies, and there was a sample size of more than 12,000 subjects. And again, there was a positive study that we have substantial reduction in heart failure hospitalizations, also a 20% reduction of cardiovascular death or first hospitalization for heart failure. And the treatment were consistent across all subgroups, including patients at the highest end of the ejection fraction spectrum and those that were already treated with other heart failure medications. So there was another positive trial that also improved not only heart events, but also quality of life, as assessed again with Kansas City questionnaire. The ADFOR study was another study about the diuretic of ketorolalamide that was again randomized, given to patients with heart failure with preserved and reduced ejection fraction. And those patients took at least 500 milligrams once daily, administered as bolus, and during the 2 days until successful decongestion. A total of 519 adults were included, and the primary endpoint was successful decongestion that was more frequent in patients receiving acetazolamide compared with placebo. But again, there was no difference between groups in composite outcomes of all-cause mortality and hospitalization for the next 3 months. So yes, it was a positive study for decongestion, but not for further follow-up of those patients. Another study was the STITCH study and the REVIVE, the BCI S2 study, but I think that it was presented previously, so we'll skip the study. And I think those was the most important highlights from the ESC according to the heart failure matters. Thank you.
So much. Thank you so much, Christina, for this excellent presentation. I will give the word rapidly to Dr. Aaysha Cader from Bangladesh with her brilliant presentation also. Okay, Aaysha, you have the word, and then we will have not more than 7 minutes of discussion. It's a Friday evening. Our panelists did our best to participate, so we should not abuse. Thank you so much, Aaysha. You have the word.
Thank you, Alex. I'll very quickly run through the trials that are mentioned on this opening slide and a quick synopsis of the non-cardiovascular surgery guideline. So let's start off with Invictus. It has a lot of relevance for lower middle income countries with over 40 million people being affected with rheumatic heart disease associated AF. So this was an international investigator-initiated open label randomized control trial with blinded outcomes assessment and a non-inferiority design. The population included rheumatic heart disease associated AF that was echocardiographic proven RHD with atrial fibrillation or flutter, and either mitral stenosis defined as a valve area of less than or equal to 2 square centimeters, or a CHA2-VASc score greater than or equal to 2. Patients who also had LA clots and spontaneous echo contrast on echocardiography in their left atria were also eligible for inclusion. These patients were then randomized 1:1 to rivaroxaban 20 milligrams daily or any locally approved vitamin K antagonist. So this was undertaken in low middle income countries, mainly Asia, Africa, and Latin America, across 138 centers, reflecting a typical rheumatic heart disease AF cohort, where the majority of patients, over 72%, were women. Mitral stenosis was predominant at over 85% across both groups, and a CHA2-VASc score of 0 to 1 was about 43% versus 44%, reflecting that the main contribution to the AF was really the mitral stenosis. So in terms of drug compliance, there was remarkable VKA compliance at 96.4%, but there was permanent discontinuation of about 23% in the rivaroxaban arm. Of note is that 1/3 of these patients switched over to VKA because they required mechanical valve replacement and therefore needed to be on VKA. Irrespective, the compliance is remarkable. In terms of the primary endpoint, we know that there was a 25% increase in the primary endpoint, which was a composite of stroke, systemic embolism, death, and MI for rivaroxaban as compared with the VKA. Of course, because the Kaplan-Meier curves crossed at around 18 months, proportional hazards assumption was not met. So they also reported it as a restricted mean survival time difference, which was statistically significant for rivaroxaban. Also of note is that the primary endpoint was changed midway in the trial because an unblinded analysis, an unblinded interim analysis revealed that the predominant event rate was actually driven by death and not stroke and systemic embolism. So death was incorporated into the composite endpoint. And as you can see, there were significantly greater proportions of death for the rivaroxaban arm than the VKA arm, as was ischemic stroke. There were no real differences in terms of major bleeding, defined as ISTH bleeding. This was a per protocol analysis. So in effect, Invictus proved, that VKA should remain the standard of care in rheumatic heart disease associated AF, but of course there remain questions that are yet unanswered, in that the primary endpoint was primarily driven by a reduction in death, which was not explained by differences in stroke. So the mechanism and further studies in this area are warranted. Very quickly now to BOX, which looked at oxygen and BP targets in a 2x2 factorial design trial in comatose out of hospital cardiac arrest patients. We know about temperature control, but what of oxygen and blood pressure targets? So this population, as I mentioned, were adult cardiac arrest patients of presumed cardiac cause, randomized in a large catchment area of Denmark via 2x2 design. 789 OHCA patients were randomized first to a restrictive versus liberal oxygen therapy arm, and later also randomized to high versus low BP. So in terms of the results, this was a typical OHCA patient cohort. About 80% were men, 86% received bystander CPR, and about 20 minutes to ROSC. And in terms of the primary endpoint, 32% in the restrictive oxygen target and 33.9% in the liberal oxygen target group made the primary endpoint, which was not statistically significant with a hazard ratio of 0.95. So essentially a neutral trial stating that targeting of either restrictive or liberal oxygenation strategy in out-of-hospital cardiac arrest patients resulted in similar incidence of death or severe disability or coma. What of the blood pressure arm? Here, patients were randomized to a true MAP of 77 versus 63, which was calibrated. And there was a significant mean difference of about 10, as demonstrated between the two arms. And here again, the primary endpoint remained the same, but it was neutral, where there were no significant differences between the high versus low blood pressure target groups. There were also no between group differences of the secondary endpoints of all-cause death, AKI requiring renal replacement therapy, cognitive function, and neuron-specific enolase level or adverse events. So again, essentially a neutral trial. What of DANFLU-1? This was a pragmatic, open-label, active controlled randomized feasibility trial, that is important to note, conducted in Denmark, where they attempted to test the feasibility of conducting a larger scale trial by leveraging existing infrastructure and registries that are very well done in Denmark, in fact. So the outcomes here were feasibility outcomes, and of course, they also pre-specified some clinical and cardiovascular outcomes to which the trial was not powered. And they had a planned sample size of 47,000 patients, who were randomized to a high-dose quadrivalent influenza vaccine versus a standard-dose quadrivalent influenza vaccine, and then followed up by registry-based follow-up for clinical outcomes. And this was, as I said, essentially done to assess the relative vaccine, to assess the feasibility of a larger trial, which would assess the relative vaccine efficacy of high-dose versus standard-dose quadrivalent influenza vaccine against cardiovascular and respiratory hospitalizations and mortality in an elderly adult population. So these patients were 65 to 79 years. And of course, recruitment was fantastic, one would say, because at least 11,000 patients were enrolled in the first 15 days. So feasibility was demonstrated. And in terms of cardiovascular endpoint, of note, this is exploratory. There was a reduction in hospitalization for influenza and pneumonia, as well as all-cause death in the high-dose arm. But of course, this trial was not powered for these clinical endpoints. So in effect, DANFLU-1 demonstrated the feasibility of conducting a large pragmatic RCT, leveraging existing infrastructure for trial processes, but these exploratory endpoints require confirmation with a larger, better powered trial. We can't not talk of COVID. This was a trial coming out of the United States, where patients with COVID-19 requiring ICU level care were once again randomized to either full dose versus prophylactic standard dose oral anticoagulation, and also to clopidogrel versus no clopidogrel if they were not on an antiplatelet trial. This was an open label trial, and they assessed outcomes, the primary composite endpoint, which was death due to venous or arterial thromboembolism, pulmonary embolism, clinically driven evident DVT, type 1 MI, stroke, and systemic embolism, as well as ALI. And they assessed it by the win ratio as well as the time to event analysis. So essentially, a win ratio of greater than 1 would confirm clinical benefit for full dose anticoagulation, as was demonstrated with a statistically significant p-value here, but this is not so for clopidogrel. And this, as I mentioned, was the Kaplan-Meier curves of a time to event analysis demonstrating the same. Of note is that the primary endpoint was mainly driven by venous thromboembolism. What of bleeding? There was no significant major bleeding, but there were significant differences in terms of greater gastro severe and moderate bleeding in the full dose anticoagulation arm. So a strategy of full dose anticoagulation presumably reduced thrombotic complications versus standard dose anticoagulation, with increased bleeding, which is primarily driven by transfusions in hemodynamically stable patients. However, we need to take these results with a pinch of salt, because it needs to be considered in the limitations of the fact that the trial was stopped early due to waning COVID rates. 390 patients were randomized, and the thrombotic events were lower than expected, which would question the power of the sample size. Very quickly now, going on to the non-cardiac surgery, the cardiovascular assessment and management of patients undergoing non-cardiac surgery guidelines. 147 recommendations were made, all of which can be read on, as those before me have mentioned, in the pocket guidelines as well as the main paper. And in terms of what is new, they had looked at clinical risk evaluation, preoperative assessment tools, general risk reduction strategy recommendations, as well as management of specific diseases, including a wide spectrum, including coronary artery disease, severe aortic stenosis, hypertension, and arrhythmias, the perioperative monitoring and anesthesia, as well as postoperative cardiovascular complications. So in terms of preoperative, no one specific risk score was recommended, although they looked at a few. And in terms of the recommendation and accurate history, clinical examination was class 1, as well as advice on stopping smoking for at least 4 weeks prior to non-cardiac surgery where that could be done, as well as optimization of guideline-directed medical therapy. And in terms of intermediate and high-risk non-cardiac surgery, as you can see, the recommendation is also to perform ECG as well as biomarkers. Which biomarkers? Troponin I or T has been recommended as class 1, as it is useful not only for preoperative risk stratification, but also for the diagnosis of perioperative MI. And an NT-proBNP has been recommended as class 2A. These are for patients who have a known cardiovascular disease risk, a cardiovascular risk factors, including age of more than 65, or those with symptoms suggestive of CVD. What of those with previously unknown murmur, angina, dyspnea, or peripheral edema? In these patients with a newly detected murmur and signs and symptoms, a transthoracic echocardiography is a class 1 recommendation if they have symptoms, or those with a murmur suggesting clinically significant pathology. As I mentioned, smoking has been recommended as a class 1 recommendation for 4 weeks prior to non-cardiac surgery, as well as an optimization of guideline-directed treatment of CVD and CV risk factors. The routine initiation of a beta blocker perioperatively is not recommended. That is a class 3 recommendation, and it is new. And a class 2A recommendation is to consider interruption of SGLT2 inhibitors for at least 3 days before intermediate or high-risk NCS. What of antiplatelet therapy? This is about interruption of antiplatelet therapy. If the indication for PCI, or indeed the indication for DAPT, is ACS or PCI with high ischemic risk features, the recommendation is to continue it for 12 months with the class 1 recommendation. But if that is not the case, it can be reduced to 6 months with a further reduction to 3 months with the class 2A recommendation. What of patients with oral anticoagulation? There was a shift away from bridging therapy in this guideline, with a class 2A recommendation for bridging with unfractionated or low molecular heparin only if the patient had a mechanical AVR with thromboembolic risk, an old generation mechanical AVR, or mechanical mitral or tricuspid valve prosthesis. And bridging of oral anticoagulation is not recommended for those with low to moderate thrombotic risk. Also, those undergoing coronary artery disease, if it is ACS, the recommendation is for the diagnosis and treatment according to ACS guidelines and pathways. For those not undergoing ACS, there's an algorithm which I will skip in the interest of time. And moving on also to severe aortic stenosis. Of note is in patients with intermediate or high risk non-cardiac surgery, and those at a low risk for valve procedures. Following a heart team review, TAVI or SAVA has been recommended as class 1, whereas in case of high valve procedure risk, balloon aortic valvuloplasty before NCS, if feasible, has been the recommendation. There are also recommendations, as I said, for a number of specific diseases, including arrhythmias, chronic arterial hypertension, where the recommendation is to avoid large perioperative fluctuations of blood pressure, and also cardiac implantable electronic devices. What of perioperative blood pressure? The recommendation is to avoid intraoperative mean arterial pressure decrease of more than 20% from baseline values, or to a level of below 60 to 70 millimeters of mercury, for greater than 10 minutes. And there were also extensive algorithms for perioperative myocardial infarction, which I will skip in the interest of time. And I believe I've made it within the 6 minute stipulated period. Thank you for listening, and over to you, Alex.
Thank you for this marathon. It's brilliant. Biljana, you have the word.
Okay, first of all, 2 messages. You're all invited to Belgrade next year for a biannual national meeting. That's from our Madam President. So you just let me know what you want to talk about, because she doesn't have Wi-Fi coverage where she is, and her 4G is transferring to 3G, so she cannot connect. Dr. Mehran apologizes. She just landed to the West Coast with a huge delay. So, Professor Luscher, did we miss something that was your most poignant impression of the ESC?
No, I think it was a very well and comprehensive overview. It was sort of a marathon indeed. But this is also due to the fact that this was the most successful ESC Congress in terms of hotlines. I mean, never ever in a cardiology Congress where there's so many papers online in the New England, in the Lancet, currently actually #1 with 207 impact, or 202 impact factor, amazing. And Nature Medicine, European Heart Journal, you name it, JACC as well. And so I think there were many neutral trials. In fact, it is getting a bit more difficult to be positive. in medicine and cardiovascular medicine in particular, because we have become very good. So in time, in hypertension, doesn't matter how you give it. I mean, we were interested to see this because we had the Spanish trial that showed a positive effect. And maybe this is a bit more solid data set, so probably it doesn't make a difference. I think Val Fuster's trial showed something we know for many years, that that if you take less drugs, you're more likely to take them. And I think in a sense, it's very important to have a polypill. This may particularly also in low-income countries of huge importance. The rheumatoid valvular heart disease trial I find extremely interesting, and it shows that vitamin K in valvular heart disease seems to still be the master. This is the case also for metallic valves, as has been published some years ago in the aortic position, now also AFib and rheumatic valve disease. So in valvular heart disease, we have to be careful. It's very complicated. In TAVI, it is actually dangerous. So we learned a lot about this. PCI, and it's a shame that Roxana couldn't make it, is very disappointing. I mean, it seems that any patient that comes acutely, we do really make a difference. In patients that are stable with or without heart failure, or renal failure, as a matter of fact, we don't make a difference. So it seems, first of all, you would say that the event rate is not so high, but in the kidney guys, it was actually quite high, and yet we didn't make a difference. So this is still difficult to understand. So in any case, if patients do have symptoms, we seem to make a difference. But of course, the British trial in patients with severe heart failure, it was really disappointing. But also STITCH was disappointing, except in a sub-analysis that was very, very small. So heart failure, we have to treat them in the classic fashion with drugs and with the amazing 4. And now we know that the sodium glucose transport inhibitors, they're all very effective, no matter what molecule you take. So it's effective in reduced ejection fraction. It's effective in mildly reduced ejection fraction. Whether it's really effective in those little old ladies' hearts that have an ejection fraction of 68, 70, 75, I doubt still. But statistically, there is a trend. But of course, the data get much less solid up there. So I think these are the most important ones I would like to comment on.
So
thank you so much, Alex. Can you close?
Yes, Professor Luscher, thank you so much for this wrap up. Would you have one particular study or report that you really impressed you during the Congress, or there are too many?
No, I would say the dapagliflozin trial was very important because in general, in the guidelines, we want to have 2 trials to get a 1A recommendation. And I think in heart failure, it was very important to have a 1A recommendation, not only in HFrEF, but also in HFpEF. So practically, this was very important. And so I would say that is the one that I take home to my clinical practice.
Perfect, thank you. So for the sake of time, we'll have to conclude this webinar. It was really a marathon. Thank you to all the speakers. Thank you, and really, really thank you, Professor Luscher. I would like to thank also to Roxana, which unfortunately could not attend due to other reasons. You will receive an email with the recording of the webinar, and as usual, we will cover all the most important congresses via webinars this year and the next year. Thank you so much once again to all of you. We highly appreciate that it's Friday evening and you took 1.5 hours to participate. And thank you once again. I'm deeply indebted to the speakers and to the panelists. Thank you so much. Have a nice evening.
Good night, everyone.
Bye.
Bye. Thanks, everyone.